the questions has been compiled from different exams like FMGE, NEET, PG, and from the very important topics. So here we go. There is a trauma patient with hypotension and respiratory distress. Chest X-ray reveals complete whiteout of the left hemithorax with tracheal shift to the opposite side. Now, what is the diagnosis? Now, here let us write the keywords first. Patient is a known case of, say, road traffic accident, and then patient is having hypotension, right? That is decreased blood pressure. Patient is having respiratory distress also. Now, what is given in the chest X-ray? Complete whiteout of left hemithorax. Okay, and this is associated with tracheal shift to opposite side. Now, opposite means right side. So, this is the classical question has been given to us. Pranati, very good morning. Now, I have deliberately kept this question, and the very first instance, I think Pranati, your first thoughts are absolutely right. The moment you give with the case of road traffic accident, hypotension, respiratory distress, the very first thought may be tension pneumothorax. But what I have done here, I have used this word white out, right? And when I say white out hemithorax, it means it is radio opaque, right? And radio opaque is what? White. But air will be always black, radiolucent. So, this white out is the trap, is the basic clue here. Otherwise, all words are trap. They are taking you towards pneumothorax, right? So, this is the only hint which is telling you that this is not a case of pneumothorax, right? So, here there is radio opacity, and whenever there is radio opacity, it means either there is fluid or maybe blood. So, based on this, your diagnosis will become pleural effusion, right? So, this is very important from exam point of view. All other conditions are taking you towards pneumothorax, but this is the only statement which says that no, pneumothorax is not the answer to this question. The answer is pleural effusion, right? So, no problem. That's pretty obvious. When we see so many keywords pointing towards one particular condition, we have a tendency to mark that answer. But please correct yourself. The moment you have this word white out or radio opaque, think of pleural effusion, right? So, this is pleural effusion. So, moving forward to next question. A 65-year-old chronic smoker presents with hemoptysis. Chest X-ray shows a central hilar mass with collapse of the right upper lobe. The horizontal fissure is elevated and the hilar shadow appears S-shaped. Most likely diagnosis. Now, again, let us write the keywords which are being given to us in the question. 65 years, it means elderly patient, chronic smoker. Okay, and then presenting with hemoptysis. Hemoptysis means coughing of blood. So the patient is coughing and the blood is coming out. So that is hemoptysis. Now chest X-ray, what it is showing? It is showing a central hilar mass. Hilar means near the hilum, right? Hilar means near the hilum of lungs. So central hilar mass, and this is associated with collapse of the right upper lobe. Lokesh, good morning. So there is collapse of right upper lobe. The horizontal fissure is elevated and there is the classical S-shaped hilar shadow. Now you have these much clues with you. The only one which is suggestive of the answer is S-shaped hilar shadow, and this is actually known as the golden S sign, right. So this is the classical clue here, which is supported by elderly patient who is a chronic smoker. So this elderly patient, chronic smoker, having hemoptysis, this all suggests that there is some malignancy, right. So there is malignancy. Now this golden S sign is suggestive of central bronchogenic carcinoma. Clear? So this all is suggestive of some malignancy here. But what is the actual malignancy? This is because of a central, this is indicated by a central hilar mass. So we will write the word central here. Then the golden S sign is classical for bronchogenic carcinoma. So what happens? The horizontal fissure, which is something like this, it gets elevated and the hilar shadow creates a reverse S sign. So this is the golden S sign, right. So somewhat like this if we see on X-ray. So this is the classical clue based on which you should answer as central bronchogenic carcinoma. Clear? So golden S sign, remember that. And obviously elder male, chronic smoker, hemoptysis, the doubt should be about a malignancy, lung malignancy, right. So this is how you will approach this particular question. Next question. A neonate develops respiratory distress immediately after birth. X-ray shows a ground glass appearance with air bronchograms and low lung volumes. Now what is the diagnosis? Now here let us write the keywords first. Neonate, respiratory distress, and this is immediately after birth. It's very important, immediately after birth. Then the chest X-ray, what it is showing? Ground glass appearance, then air bronchograms and low lung volumes. Now we have these much of clues. The classical clue which you should remember for the answer is ground glass appearance. So the moment you have any mention of ground glass appearance, especially in a neonate who is presenting with respiratory distress immediately after birth, the answer has to be hyaline membrane disease, right? Hyaline membrane disease, which is also known as the respiratory distress of newborn. And I think most of you must be knowing the pathology in hyaline membrane disease or respiratory distress of newborn. What is happening here? Deficiency of surfactant. And we know that what is the function of surfactant? Surfactant keeps the alveoli inflated. So the moment surfactant is less, the surface tension of alveoli increases, and this leads to collapse of alveoli and therefore respiratory distress. Clear? So that's a very beautiful description of hyaline membrane disease, which is also known as respiratory distress of newborn. And the classical clue which you should look in the question statement is ground glass appearance, right? So ground glass appearance or ground glass opacity on chest X-ray. Fine, please remember this. This is one very important topic and has been asked many number of times. Okay, next question. A young man presents with sudden chest pain. Chest radiograph shows absent vascular markings beyond a visible pleural line. So here let us write the keywords first. Sudden chest pain, right? There is sudden chest pain, and chest X-ray, what it is showing? It is showing absent vascular markings beyond a visible pleural line, right? So what is being seen? There is a pleural line which is seen, and after that there is no vascular marking. So this is classically suggestive of simple pneumothorax, right? Pneumothorax. I think all of you must be knowing this fact. Pneumo means air, thorax means in pleural cavity. So air in pleural cavity. Now here the complaint is sudden chest pain. Now some student, they might have this tendency to jump onto tension pneumothorax. So the moment they find anything related to pneumothorax, they think that it is tension pneumothorax. But here you have to be very cautious. This kind of presentation is not tension pneumothorax, it is simple pneumothorax, right? So please be careful. Visible pleural line, this is obviously the visceral pleural marking, right? So we see the visceral pleural marking, and there will be air between both the layers, like visceral and parietal pleural membrane, and this is simple pneumothorax. Now the question is, why not tension pneumothorax? Why not tension pneumothorax? So the differentiating points of simple pneumothorax from tension pneumothorax, let me enumerate. Number one, there will be tracheal shift to opposite side. This point is not mentioned here. So tracheal shift. Number two, there will be hypotension, which is not mentioned here. There will be raised JVP, which is not mentioned in the question. So that's why we can say that this particular given question is about simple pneumothorax. If you have any mention of tracheal shift to opposite side or mediastinal shift to opposite side, hypotension, raised JVP, then you should think of tension pneumothorax, right? So you have to differentiate simple pneumothorax from tension pneumothorax. Both the entities are different and the presentation is also different. Clear? So I hope this will not be confusing to you anymore. Next question. A child with fever and seizures undergo CT scan of head. Hyperdense lesion in basal cistern is C. So let us write the keywords. Children, a child with fever and seizures. But what is more important is the CT scan of head. Now what is being seen on the CT scan of head? You will see hyperdense lesion. Clear? So there are hyperdense lesion, and what is the location? Basal cistern. Now hyperdense means that that is indicative of bleed. Clear? So the moment you have this word hyperdense on CT scan, think of blood or bleeding somewhere. Now based on this particular anatomical location, you will answer this particular question. So if there is any mention of bleeding in basal cistern or fissures, clear, or any location related to CSF, think of bleeding in CSF. That is, and what is the location of CSF? CSF is present in subarachnoid space. We know that CSF is present in subarachnoid space. So if there is bleeding in subarachnoid space, bleeding here, the condition will be known as subarachnoid hemorrhage. Right? So this is how this particular clue is giving you an idea that this question is about subarachnoid hemorrhage. Okay, so what is the answer here? Subarachnoid hemorrhage. So whenever there is any mention of bleeding in basal cisterns or fissures like sylvian fissure, then you should think of bleeding in subarachnoid space, and the entity is subarachnoid hemorrhage. So very simple to understand, but you have to be very careful, right? Because the usual tendency is to run after extradural or subdural. Don't do that. Read the question properly, take your time, and these are very scoring questions. Like every year, every exam, we have one question from this topic. So please don't do any sort of mistake. Now, a road traffic accident victim develops loss of consciousness. CT scan of head reveals a biconvex hyperdense lesion, most likely diagnosis. So again I will write the keywords first. Here patient is a case of road traffic accident, then having loss of consciousness, but CT scan of head is important here for evaluation. So what it is showing? Hyperdense lesion, right? So it is showing hyperdense lesion, and what is the shape? It is biconvex. I told you before, hyperdense. The moment you find this word hyperdense, always think of bleeding, right? So hyperdense means there is bleeding somewhere in the head, right? So there is bleeding somewhere. Now look at the shape of the bleed, biconvex. Bi means both, so it means the shape, this is one side convexity and this is another side convexity. So this is known as biconvex. So if you have this kind of opacity or hyperdense lesion on CT head after road traffic accident, this is more suggestive of extradural hemorrhage. Clear? So this is extradural hemorrhage. Now it is also known as epidural hemorrhage. So extradural hemorrhage, epidural hemorrhage, it is same thing, right? Epi means above, extra means outside. So there is bleeding which is occurring outside the dura mater, so it is known as extradural or epidural hemorrhage. Clear? So this is how you will reach up to your answer, that this is a case of extradural hemorrhage, and this is especially seen after road traffic accident. Clear? I am very sure you will not do any sort of mistake in this kind of question. So this is, and just one more word which might help you in exam, source of bleeding. We are saying that there is hemorrhage. So what is the source? The source is middle meningeal artery. Okay, so this is middle meningeal artery. So it means the source of bleeding is arterial blood. Okay, middle meningeal artery. So I am very sure if there is any case history kind of question, you will get the answer. If there is an image of CT scan, just look at this lemon kind of appearance. Okay, so this is somewhat like, you can say, lemon kind of appearance. The answer has to be extradural or epidural hemorrhage. Clear? Please don't do any mistake. Next question. An elderly alcoholic presents with gradually worsening headache. CT scan reveals crescent shaped extra-axial collection which is crossing sutures. Diagnosis. So again we will write the keywords first. Now here the patient is elderly, alcoholic. Now please note that there is no mention of road traffic accident, right? So there is no road traffic, no history of, you can say, road traffic accident. I am just adding it from my side. Then complaint is gradually worsening headache. Now CT scan of head, what it is showing? crescent shaped, right, crescent shaped extra axial collection, and this is crossing sutures of skull. Clear? So this is what is given to you. Now there is only one indication based on which you can simply jump onto your answer, right? Now let us see what this crescent word is. Crescent word means something like a moon. So this is crescent shaped hyperdense lesion, and you can call it like a banana, right? So in an elderly alcoholic patient who is coming with gradually worsening headache, and if we see a crescentic hyperdense lesion on CT scan of the head which can cross suture, the answer will be subdural hemorrhage, right? So what will be the answer? Subdural hemorrhage. Now what is this word sub? Sub means below. Clear? So sub means below. So this is the classical subdural hemorrhage, in which the patient is elderly, and then CT scan will show you crescent shaped hyperdense lesion. And now here again the same question, what is the source of bleeding? In extradural we discussed that it is arterial, but here it is venous. And when I say venous, which veins? Emissary veins or the connecting veins, right? So they veins, they get ruptured. So the basic difference between epidural and subdural is the source of bleeding. In extradural or epidural it is arterial, in subdural it is venous, from veins, right? So please remember these two are very frequently, any one of the two is definitely going to be there in your paper. The presentation might vary. Now next question, a patient with head injury has normal CT but remains unconscious, and then MRI later shows multiple punctate hemorrhages at the grey white matter junction. Now diagnosis. Now here let us write the keywords first. History of head injury, and then patient became unconscious. CT scan of head, because for acute cases of bleeding in the brain we go for CT head, right? Because that takes around only 2 minutes, and acute bleeding is very well visualized on CT's head. But here it is coming out to be normal, but the patient is unconscious, and after some time when we do MRI, what we see? We will see punctate hemorrhages, and these are classically at the grey matter white matter junction. So the moment you have this presentation where the CT is normal but MRI is picking up the hemorrhages, think of DAI. Okay, now what is DAI? Diffuse axonal injury, right? So CT scan head is normal, but MRI will show you punctate hemorrhages, dot dot like this. So this means punctate hemorrhages, dot dot, right? So the bleeding will be like this. It will not look like a lemon or a banana, nothing like that. This is punctate hemorrhages at the junction of gray matter, white matter. But classically, the important clue is CT is normal. Patient is unconscious. There is history of head injury, but the CT scan is not showing us anything. MRI is only helping us to see those punctate hemorrhages. So this is classical of diffuse axonal injury. So we have discussed all the 4 types of bleeding: subarachnoid hemorrhage, extradural or epidural hemorrhage, the third one is subdural hemorrhage, and the fourth one is diffuse axonal injury, right? So these are the 4 important patterns of head injury, and you should be very clear in picking up the keywords, because this neurosurgery, trauma of neurosurgery is very important from exam point of view. Next question. A patient presents with severe flank pain. X-ray, kidney, ureter, bladder shows a hyperdense calculus in ureter. Investigation of choice. Now here, let us write the keywords first. Known case of severe flank pain, right? So there is pain at the back side of the lumbar region in the flanks. Then X-ray was done, kidney, ureter, bladder, KUB region, kidney, ureter, bladder. Now what it is showing? It is showing a hyperdense calculus, and the location is ureter, right? So hyperdense calculus. Now why it is hyperdense? Because it is containing calcium, so it is shining bright. So hyperdense. So hyperdense because of calcium. Clear? And calculus, this is obviously the stone. So this is a case of ureteric stone, or you can say ureteric calculus. Now the investigation of choice in such cases is non-contrast CT scan. Clear? So this is non-contrast, because what happens? So you will write it NCCT, non-contrast CT scan. Now why non-contrast? Because contrast is white in color, so, and the stone is also white in color. So if you give a contrast, the shadow of or the impression of the stone will be masked in that shadow of the contrast. So never give contrast if you are trying to figure out the stones in KUB region. Okay. So non-contrast, especially for ureteric calculus, we go for non-contrast. Although in this particular case, already the stone has been diagnosed in ureter, and now this is IUC, right? Investigation of choice. Now, if the question is about initial investigation, initial best investigation, then usually we go for ultrasound, right? So initial best investigation, we go for ultrasound because we know that there is no radiation hazard, but with CT scan there is radiation hazard. So CT scan is not preferred straight away. Better go with USG. If USG is inconclusive and patient is having symptoms of ureteric calculus, then we can go for non-contrast CT scan, right? So this is the approach. Now a neonate develops bilious vomiting. X-ray shows 2 large air-filled structures with no distal bowel gas. Diagnosis. Now I think this is one of the easiest question, and this has been asked many number of times. So now the child is the patient is a neonate, and he is having bilious vomiting. X-ray is showing two large air filled structures and there is no distal bowel gas. Now, I think the moment you have this kind of presentation, the answer is pretty straightforward. You have two large air filled structures, right. So, this is what is known as the double bubble sign. Clear? So, this is the classical double bubble sign. The moment you have this kind of presentation, you can think of this particular sign, and the condition is duodenal atresia. Okay, atresia means narrowing. So, atresia means narrowing. So, this is duodenal atresia. Now, bilious vomiting, it means there is bile in vomitus. So, whatever the patient is vomiting, it is containing bile, and if we know the anatomy of the second part of duodenum, this is the opening of CBD which joins with the major pancreatic duct. So, this is the major pancreatic duct, this is the common bile duct. So, what is happening? The obstruction is somewhere here, atresia is somewhere here. So, this is the duodenal atresia. So, what is happening? The bile is coming like this, and when the patient will vomit, it will go and it will come out through the mouth like this. So, bile will come in vomitus. It means the obstruction is distal to common bile duct opening, right. So, that is the anatomical fact here. So, this is classically duodenal atresia. Okay. So, this is duodenal atresia. This kind of presentation can also be seen in one more condition, and that is known as annular pancreas. So, double bubble sign can be seen in annular pancreas as well. So, two conditions may show this kind of sign. Now, two large air filled shadows. So, one is in the air in stomach, and second shadow is the air in proximal duodenum, right, and there is no air shadow distal to that. So, this is double bubble sign, classical double bubble sign suggestive of duodenal atresia, or at times the answer may be annular pancreas if it is not in the, if duodenal atresia is not in the option. Okay. Chalo, next question. A hypertensive patient presents with tearing chest pain radiating to the back. CT angiography shows an intimal flap dividing the aorta into two channels. Now, what is the diagnosis? So, again let us write the keywords first. Known case of hypertension, right, BP remains high, increased blood pressure. There is tearing chest pain, very severe chest pain, and it is radiating to the back through the chest wall, it is radiating back, and CT angiography, clear. So, CT angiography, it is showing intimal flap, right, of tunica intima, and this flap is dividing the aorta into two channels, right, into two channels. Now, this point is very suggestive of aortic dissection. So this particular point, like chest pain, tearing through the chest, going to the back, between the two scapula, that is interscapular region, think of aortic dissection. Now what is shown on CT angiography? There are two channels. Normally there should be one channel, but now there are two channels. So this is known as the double lumen sign. So now there are two lumens or two channels. One is the normal or the true one, and second is the false channel which has been created because the blood is tearing the intima and it is now dissecting the layers of the aorta, right? So therefore double lumen sign suggesting aortic dissection. There is a tear in the intima. Now the blood from the lumen of the aorta is actually entering through that false opening, and then it is separating the layers of the wall of aorta. So that is known as dissection, like just like we do dissection in anatomy. So here the layers are dissected out because the flow of blood is so forceful, it just keeps on separating. And on CT angiography we will see that there are two lumens, one is true lumen, another is false lumen. So that's very classical for aortic dissection, which is commonly seen in hypertensive patients, right? So this is how you will reach up to your answer. So this is enough for this session. I am very sure you must have enjoyed the session. So very shortly I'll come back with another subject. Till then, keep on studying. God bless. Bye bye.